Hello, everyone. I am Sala Doctor. Today we're going to talk about a cornerstone of critical care, nutritional support and enteral feeding. This is not just about giving calories, it's an active, life-sustaining medical therapy. We'll discuss why it's so crucial, how to do it safely, and how to manage the challenges that come with it. Before we move on, let's think together. How long do you think a critically ill patient can go without nutrition before complications begin? Before we begin, let's take a quick look at today's learning objectives. By the end of this session, you should be able to understand the basic concepts and importance of nutritional support. Identify the different methods, oral, enteral, and parenteral nutrition. Recognize when to start or avoid enteral feeding through indications and contraindications. Describe the feeding routes like NG, NJ, and PEG. Perform pre-feeding assessments, such as tube placement check and patient positioning. Apply correct feeding techniques and nursing care to prevent complications. And finally, monitor the patient's progress through weight, lab values, and feeding records. Which part do you think is the most challenging in real ICU practice, starting the feeding or maintaining it safely? Let's start with the definition. What exactly is nutrition support? It simply means providing nutrients to patients orally, enterally, or parenterally, with the goal of maintaining or achieving optimal nutritional status. It's not just giving food, it's a medical therapy designed for patients who can't meet their needs through a normal diet. For example, patients who are intubated, have swallowing problems, or severe illness that increases energy demand. So if the patient cannot eat enough by mouth, we step in with medical nutrition, either through a feeding tube or through IV nutrition like this one in the picture. Point to the bag on the slide. Now let's talk about why nutrition is so important in the ICU. Critical illness puts the body into a hypermetabolic state, meaning the body burns energy and protein much faster than normal. If we don't replace that energy, patients start losing muscle mass, including respiratory muscles, and that's why they stay longer on the ventilator. Proper nutrition also supports immune function, helping the body fight infection and sepsis. It promotes wound healing, since protein and nutrients are needed for tissue repair. And finally, adequate nutrition improves patient outcomes. Studies show fewer infections, shorter ICU and hospital stays, and even lower mortality. Here are the main methods of nutritional support we use in the ICU. First, the oral diet. It's for patients who are alert and able to swallow with a working GI tract. But in ICU, that's often a challenge because many patients are intubated, weak, or sedated. Next, we have oral nutritional supplements, ONS, like protein shakes or high-calorie drinks. These are great for patients who can eat but still don't meet their daily needs. Then, enteral nutrition, EN, feeding through a tube directly into the stomach or small intestine. We often say, if the gut works, use it. Because using the GI tract helps maintain gut integrity and lowers infection risk. Finally, parenteral nutrition, PN. When the GI tract can't be used, we deliver nutrients directly into the bloodstream through a central line. Let's compare enteral nutrition and parenteral nutrition route. Enteral nutrition uses the GI tract, for example, NG or NJ tubes. Parenteral nutrition goes directly into the bloodstream through a central line. Physiology, enteral nutrition is more natural. It keeps the gut working and maintains the gut barrier, while parenteral nutrition bypasses the gut completely. Cost, enteral nutrition is much less expensive, while parenteral nutrition is significantly more costly. Risk of infection, enteral nutrition has a lower risk, though aspiration can happen. Parenteral nutrition, on the other hand, has a higher risk of line-related sepsis. Complications, enteral nutrition, think of diarrhea, aspiration, or tube dislodgement. Parenteral nutrition, hyperglycemia, liver dysfunction, or infection. Nursing role, both require close attention. For enteral nutrition, frequent checks, residuals, and tolerance. For parenteral nutrition, strict sterile technique and line care. Now let's look at when we should start enteral nutrition. First, mechanical obstruction. Patients with oropharyngeal or esophageal tumors or strictures may not be able to swallow safely, so they need tube feeding. Second, neurological impairment, stroke, brain injury, or low consciousness, GCS less than 9. These patients can't protect their airway or feed themselves. Third, high metabolic demand. Think of major burns, trauma, or sepsis. The body needs a lot more energy and protein, so early feeding is crucial. Lastly, inability to consume enough orally. Patients with severe respiratory failure on ventilators or extreme weakness often can't eat enough, so we use enteral nutrition to support them. Now that we know when to start enteral nutrition, let's talk about when we should not start it. We divide the contraindications into two types, absolute and relative. Absolute contraindications mean Do not feed through the gut at all. Examples: bowel obstruction, nothing can pass through. Ischemic bowel, blood flow is cut off, feeding will worsen the injury. Severe paralytic ileus, the gut is not moving. Significant GI bleeding, we wait until the bleeding is controlled. Relative contraindications are temporary, feeding may be delayed or adjusted. For example, severe diarrhea or vomiting, high output fistulas, hemodynamic instability, for example, patient on high dose vasopressors. Now let's look at the different routes for enteral feeding. We usually divide them into short-term and long-term routes. Short-term, 4 weeks. The most common one is the nasogastric tube. It goes into the stomach and can be inserted right at the bedside. It's easy and quick, but there's a higher aspiration risk. In the ICU, this is our most common initial route for ventilated patients. Next, the nasojejunal tube. It goes further down into the jejunum. It has a lower risk of aspiration and is used when the patient has gastric intolerance. Long-term, 4 weeks. We use PEG, percutaneous endoscopic gastrostomy. It goes directly into the stomach. It's more secure and comfortable for long-term use. And if the stomach can't tolerate feeding, we use PEJ, percutaneous endoscopic jejunostomy, into the jejunum. Here we can clearly see the two most common feeding tubes used in the ICU. At the top, this is the nasogastric tube, NGT. It goes from the nose through the esophagus and into the stomach. It's quick and easy to insert, but remember, it carries a higher risk of aspiration, especially in ventilated or unconscious patients. Below, we have the nasojejunal tube, NJT. It passes through the stomach and reaches the jejunum. This tube is used when the patient cannot tolerate gastric feeding, for example, those with reflux, vomiting, or delayed gastric emptying. Now that we know the routes, let's look at the types of enteral formulas. Choosing the right formula is just as important as choosing the right route. First, standard polymeric, used for patients with normal digestion and absorption. It contains intact proteins, carbohydrates, and fats, like a complete meal in liquid form. Second, hydrolyzed or elemental formulas. These are predigested. Proteins are broken down into peptides and amino acids. They're for patients with impaired digestion or absorption, like pancreatitis or short bowel syndrome. Third, disease-specific formulas. These are tailored for certain conditions. For example, renal formulas with less potassium and phosphorus, hepatic formulas with more branched-chain amino acids, and diabetic formulas with controlled carbohydrates. Finally, modular formulas. These contain one single macronutrient, like protein powder, which can be added to other feeds to meet specific needs. Before you hang the formula, always check the tube placement first. This is one of the most important safety steps in enteral feeding. For NGT or NJT, if you're ever unsure, confirm with an X-ray. pH testing is only for routine rechecks, not for initial verification. A pH less than or equal to 5.5 means the tube is correctly in the stomach, but a pH greater than 6 suggests it might be in the airway, danger. For PEG or PJ, check the external length marking to make sure the tube hasn't moved, and always inspect the stoma site for redness, leakage, or infection. Before starting feeding, we also need to check gastric residual volume, GRV, but only for gastric tubes. We aspirate the stomach contents before intermittent feeds, and every 4 to 6 hours during continuous feeding. In the past, we used to stop feeding when GRV was high. But new guidelines say, if the patient has no abdominal distension or vomiting, feeding can continue even if GRV is more than 500 milliliters. So we no longer stop feeding just because of a number. Next, patient positioning. This is the number one way to prevent aspiration. Always keep the head of bed, HOB, elevated to 30 to 45 degrees during feeding, and maintain it for at least 30 to 60 minutes afterward. Let's start with the first feeding method, continuous drip. What it is. This means the feeding formula is given slowly and continuously over 24 hours using an enteral feeding pump. It's steady, gentle, and easy for the body to tolerate. Best for critically ill patients, especially those in ICU. When starting feeds, we always begin slowly to assess tolerance. Patients with poor gastric tolerance, who can't handle large volumes. And for jejunal feeding, this is the preferred method. Nursing actions: set the prescribed rate on the pump, flush the tube with 30 milliliters of water every 4 hours, and check gastric residuals every 4 to 6 hours if it's a gastric tube. Next, let's look at intermittent or bolus feeding. This method is more like a meal. What it is: a larger volume, around 250 to 400 milliliters, is given over 20 to 30 minutes, several times a day, similar to how we normally eat. Best for patients who are transitioning to oral diets, stable patients with good GI function, and those using gastric tubes, PEG or NGT, in non-critical settings. Nursing actions: use a syringe or gravity drip bag for feeding. Always flush before and after feeding with about 30 milliliters of water to prevent clogging. Check residual before each bolus feed. And keep the head of bed elevated to prevent aspiration. Let's talk about something simple but super important: flushing the tube. Why do we flush? 2 reasons. 1. To prevent tube clogging. The number one cause of blockage is medication residue. 2. To provide free water, helping meet the patient's hydration needs. How to flush: use 30 milliliters of warm water. Flush before and after each medication. Flush before and after each bolus feeding. During continuous feeding, flush every 4 to 6 hours. And remember, always use a 60 milliliter syringe, because smaller syringes create too much pressure and can damage the tube. Now let's review how to prevent aspiration, one of the most serious complications of enteral feeding. 1. Maintain HOB greater than or equal to 30 to 45 degrees at all times. This is the number one most effective way to prevent aspiration. Keep the head of bed elevated during feeding and for at least 30 to 60 minutes after. 2. Verify tube placement, especially for NGT, before each use and check regularly. If in doubt, stop and confirm. 3. Check gastric residuals according to your unit protocol. 4. Assess for early signs of aspiration, new cough, wheezing, or rapid breathing during feeding. Increased respiratory secretions. Fever without another clear cause. 5. Perform regular oral care. This reduces bacterial growth in the mouth and helps prevent aspiration pneumonia. Here you can see what we mean by keeping the head of bed elevated. The image on the left shows 30 degrees. This is called the semi-Fowler's position. It's usually the minimum angle we maintain for feeding. On the right, 45 degrees, the Fowler's position, is even safer for patients at high risk of aspiration, such as those who are ventilated or sedated. Even a small difference in angle can decide whether a patient aspirates or not. Now let's look at the common complications of enteral feeding and how we can prevent them. They can be grouped into 3 major categories: gastrointestinal, mechanical, and infectious. 1. Gastrointestinal: diarrhea, usually caused by antibiotics, formula contamination, or feeding too fast. Nausea/vomiting, also related to high feeding rate or delayed gastric emptying. Constipation, often due to low water or fiber intake, inactivity, or medications like opioids. Aspiration, caused by poor positioning or high gastric residuals. 2. Mechanical: tube clogging, from inadequate flushing or incompatible medications. Tube dislodgement can happen if the patient pulls the tube accidentally or is confused. Skin breakdown, from leakage of gastric contents around the tube site. 3. Infectious: stomacide infection, due to poor skin care or bacterial contamination. Aspiration pneumonia, caused by inhaling gastric contents. One common issue we face during enteral feeding is high gastric residual volume, or GRV. Traditionally, we used to stop feeding when gastric residual volume exceeded 200 or 250 milliliters. But new evidence shows that gastric residual volume alone isn't a reliable indicator of intolerance. What should we do now? If gastric residual volume is more than 500 milliliters, check for abdominal distension or vomiting. If the patient looks comfortable and there's no distension, feeding can continue while monitoring closely. If high gastric residual volume persists, the doctor may prescribe prokinetic drugs like metoclopramide, or consider switching to post-pyloric, jejunal feeding. When giving medications through the feeding tube, there are a few important safety rules to remember. 1. Liquid formulations are always preferred. They're easier to flush and less likely to clog the tube. 2. Never crush enteric-coated or sustained-release pills. Crushing these can destroy the coating and cause side effects or overdose. 3. Crush each medication separately into a fine powder, then mix it with 15 to 30 milliliters of warm water before giving. 4. Give one medication at a time, with 10 to 15 milliliters of water between each to prevent clogging. 5. Never mix medications with formula. It can cause tube blockage or drug-nutrient interactions. 6. After giving the last medication, always flush with a full 30 milliliters of water. Now let's move on to parenteral nutrition. This is used when the GI tract cannot be used safely or effectively. Let's look at the main indications. 1. Non-functioning GI tract, for example, paralytic ileus or prolonged intestinal obstruction, where the gut simply isn't moving or open for feeding. 2. Severe GI dysfunction, Cases like short bowel syndrome, high output fistula, or severe malabsorption, nutrients cannot be absorbed properly, so feeding through the vein is needed. 3. Inability to access the GI tract, for example, after major surgeries or injuries that prevent tube placement. 4. Failed EN trials, when the patient cannot tolerate enteral feeding despite all attempts and adjustments. 5. Life-saving use, for critically ill patients who absolutely cannot receive enteral nutrition, parenteral nutrition becomes their only source of nutrition and energy. Once we start nutrition therapy, whether enteral or parenteral, we must monitor daily progress. 1. Daily weights. This is the gold standard for nutritional monitoring. It tells us the real trend. Weight loss suggests underfeeding or catabolism. Weight gain may indicate fluid overload, not always good nutrition. Always weigh at the same time each day for consistency. 2. Strict intake and output. We must accurately record all fluids. Intake includes 4 fluids, enteral formulas, water flushes, and medications. Output includes urine, stool, vomit, and drain outputs. These help assess the patient's hydration status and detect imbalances early. 3. BMI, good for initial assessment, but not very useful for daily monitoring, since fluid changes can alter weight temporarily. Now let's talk about how parenteral nutrition is given, and what's inside it. There are 2 main types. 1. Peripheral parenteral nutrition, PPN, uses a peripheral vein, usually in the arm. The solution is less concentrated, so it's used only for short-term support, typically less than 7 to 10 days. Best for patients with lower nutrient needs or those who are transitioning from oral/enteral feeding. Tube total parenteral nutrition, TPN, uses a central vein, like the subclavian or internal jugular. The solution is highly concentrated and can meet all nutritional requirements. It's designed for long-term use or patients with high energy needs or fluid restrictions. Finally, remember, parenteral nutrition solutions are customized for each patient. They contain dextrose, amino acids, lipids, electrolytes, vitamins, and minerals. Now let's talk about the nursing role in caring for patients on parenteral nutrition. 1. Line care. This is critical. Parenteral nutrition runs through a central line, which is a direct route into the bloodstream. We must use meticulous sterile technique to prevent catheter-related bloodstream infections. Always disinfect hubs properly and change dressings per protocol. 2. Metabolic monitoring. We need to closely monitor for 2 major metabolic issues: refeeding syndrome. When nutrition starts in a malnourished patient, their electrolytes, especially phosphate, potassium, and magnesium, can drop dangerously. Always check and correct these before and after parenteral nutrition initiation. Hyperglycemia, very common due to the high glucose content of parenteral nutrition. Monitor blood sugar regularly and manage according to the insulin protocol. 3. Transition to enteral nutrition. As the GI tract recovers, parenteral nutrition should be gradually reduced while enteral feeding is increased. This prevents rebound hypoglycemia and helps restore gut function. This slide explains one of the most dangerous complications of nutrition therapy, refeeding syndrome. It's a potentially fatal shift in fluids and electrolytes that happens when a severely malnourished patient starts receiving nutrition, whether enteral or parenteral. Let's look at the core mechanism. During starvation, the body adapts by switching from using glucose to using fat and protein for energy. When we suddenly start feeding, there's a rapid influx of carbohydrates. The body shifts back to glucose metabolism. This triggers a massive release of insulin, which drives electrolytes, especially phosphate, potassium, and magnesium, into the cells. The result? Severe hypophosphatemia, hypokalemia, and hypomagnesemia, which can cause cardiac arrest, respiratory failure, or death if not recognized early. Now let's look at what happens when refeeding syndrome develops. The consequences can affect every organ system. 1. Cardiac. Low phosphate and potassium lead to arrhythmias, heart failure, or even sudden cardiac death. That's why early electrolyte correction is life-saving. 2. Neurological. Patients may develop seizures, delirium, weakness, or even paralysis, because the brain and nerves can't function properly without enough phosphate and magnesium. 3. Respiratory. Low phosphate weakens the diaphragm, causing respiratory failure, especially dangerous for ventilated patients. 4. Hematological. Oxygen delivery drops due to low 2,3 DPG levels in red blood cells, making tissues hypoxic even when oxygen looks normal on the monitor. 5. Metabolic. Fluid retention and edema are also common, as insulin shifts sodium and water into the cells. After learning how dangerous refeeding syndrome can be, let's talk about how to prevent it. 1. Screen and risk assess patients before starting nutrition. We must identify who's at risk, for example, patients who are malnourished, fasting for many days, or have chronic illnesses. 2. Replete deficits first. Correct phosphate, potassium, and magnesium levels before feeding begins. If you start feeding without correction, you can trigger the syndrome immediately. 3. Give thiamine, vitamin B1. Administer 200 to 300 milligrams for thiamine before starting feeding and continue for the first 3 days. This supports glucose metabolism and prevents lactic acidosis. 4. For high-risk patients, start low, around 10 kilocalories per kilogram per day, then gradually increase as the patient tolerates feeding. Go slow to save lives. 5. Monitor closely. Check phosphate, potassium, magnesium, and glucose at baseline, then daily for the first 3 to 5 days. When monitoring nutrition therapy, lab values tell us how well our plan is working and whether complications are developing. 1. Prealbumin has a short half-life, only 2 to 3 days, so it's the best marker for short-term response to nutrition therapy. If it rises, it usually means the patient is improving nutritionally. 2. Albumin has a long half-life, around 21 days, so it reflects chronic illness or inflammation, not acute nutritional changes. Don't overinterpret low albumin. It often means the patient is sick, not necessarily malnourished. 3. Electrolytes, Na, K, Mg, Phos. Monitor these closely, especially in malnourished patients starting feeding. Large drops in these values can signal refeeding syndrome. 4. Glucose, hyperglycemia is common, particularly in PN. Check blood glucose frequently and follow your insulin protocol for control. Finally, let's talk about something simple, but absolutely essential: documentation. Good feeding records are the backbone of nutritional care. If it's not documented, it didn't happen. What to document? Formula type and rate/volume. Write exactly what was given. Water flushes, remember, they count toward total I and O. Gastric residual volumes, record every check and the trend. Patient tolerance, include notes on abdominal distension, nausea, vomiting, or stool output. Feeding interruptions, note when and why feeding was stopped, and when it restarted. These records help the dietitian and medical team evaluate whether the feeding plan is working and make adjustments if needed. As we wrap up this session, let's highlight the key takeaways from today's topic. 1. Nutrition is not just support, it's treatment. In critical care, nutrition is a vital part of recovery that improves survival, reduces infection, and shortens ICU stay. 2. Document everything. Your feeding record is not just paperwork, it's a legal document and a reflection of your nursing care. 3. Monitor meticulously. Daily weights, INO, and lab results tell the patient's story. They show us what's really happening inside. 4. Always verify, elevate, and flush. Before feeding, check tube placement, keep the HOB 30 to 45 degrees, and flush the tube regularly. These 3 steps prevent most complications. 5. Watch for tolerance and complications. Monitor for signs of aspiration, diarrhea, abdominal distension, or vomiting. Small changes can be early warning signs. Catch them before they become emergencies. Thank you so much, everyone. You've just completed one of the most important topics in critical care: nutritional support and enteral feeding. Remember, nutrition isn't just calories, it's therapy. Every feed, every flush, and every record you make contributes to your patient's recovery. Before we finish, does anyone have any questions or cases they'd like to share from their own ICU experience? If not, thank you all for your attention and participation, and keep up the amazing work you're doing for your patients every day.